Welcome everyone. Let's discuss the topic of Chyluria. Now, what is Chyluria? Chyle is basically term originate from Greek origin, which means juice, and it is a milky bodily fluid consisting mainly of lymph and emulsified fat or free fatty acid. It is usually formed in the small intestine during the digestion of fatty foods. Alright, during the digestion of the fatty foods, chyme is formed, and this is taken by lymph vessel in the small intestine. So if it is my small intestine, in my small intestine there are lymph vessels specialized which are known as lacteals, that are responsible for absorption of those chyme. Okay. So this clinical entity Chyluria is important as patient becomes fearful whenever there is milky whitish urine and immediately visits in the hospital. Now, there is a robust lymphatic system which leads to drainage of lymph in our body. This lymphatic system can be compared to the sewage system, which helps to remove unwanted toxins, waste or excess water from the body. It actually drains everything into the heart. Now this can be divided into two broad division, which drains the right upper limb, which is also known as right upper limb duct system, and other rest group, which is broad category group, which is drained by this thoracic duct. So there are two ductal system, right upper limb ductal system and thoracic ductal system, that is responsible for the drainage of limbs in the body. Now coming to the Chyluria once again, this Chyluria, that is chyle in urine, is broadly classified according to causes to parasitic and non-parasitic group. In developing countries, parasitic causes are the most common. Whereas in developed country, non-parasitic causes are mostly seen. Now, among parasitic, Ochera bancrofti shares 95%, that is the majority, while the remaining 5% is shared among tinea, ankylostomia, trichiniasis or malaria. Now, etiologically, factors for non-parasitic can be classified into trauma. This trauma can be either blunt trauma or as well as penetrating trauma, which can lead to Chyluria, as well as it can be after surgical complication of partial nephrectomy or aortoiliac bypass. It can be due to the infection or malignancy. Among malignancy, it is to be kept in mind that testicular carcinoma and AML are the majority. Alright. Okay. It can be also due to congenital abnormalities, lymphatic malformation, radiation, abscess. It can be due to the venous stasis caused by pregnancy, lymphangiomy of kidney or bladder, or stenosis of thoracic duct. Stenosis of thoracic duct usually present with chylothorax. It also present with chylous ascites and chyluria. Now, how does the Chyluria develops? That is, what is the pathogenesis of this Chyluria? Now, as I already said, chyle is composed of albumin and fat, and it may be broadly classified, this mechanism of formation of Chyluria, into two broad groups. That is due to regurgitation of chyle in urine, or due to obstructive pathology. Okay. So, chyle can go into urine broadly due to two reasons, one due to regurgitation or due to obstruction. Now, mainly it is seen due to the parasitic infestation in our country or in any developing world. Parasitic infestation is seen in the developing countries. Alright, infestation. Now, what happens is, this regurgitation theory is based upon the fact that either the buildup of toxic metabolite or an inflammatory immune reaction which becomes secondary to parasitic infestation, resulting in the development of lymphatic ectasia. it develops into ectasia, lymphatic ectasia, or varicosities that ruptures. Varicosities that ruptures. Okay, which result into release of chyle, which results into release of chyle from dilated intestinal lymphatics to the renal system. Alright, to the renal system. Now, coming to the obstructive theory, what happens in obstructive theory is that there is obliterative lymphanginitis. There is obliterative lymphanginitis. And why this obliteration occur? This obliteration occurs secondary to nothing but, yes, parasitic infestation. So, parasitic infestation can lead to both regurgitation as well as obstruction. Mechanism of regurgitation is inflammatory immune reaction which results into ectasia or rupture of varicosities, while mechanism of obstructive is obliterative lymphanginitis which leads the collateral and varicosities to cause backflow, which leads the collateral and varicosities to have a backflow. Alright. Okay. This is the mechanism how Chyluria develops. Now, how do the patient of Chyluria comes to us? Chyluria easily in 70% of the cases present with what I have already said, worrisome appearance of milky white colored urine, and patient usually comes on first visit because of the fear. Okay. Now, apart from Chyluria, that is milky white urine, there may be additional symptoms of dysuria. Dysuria means painful urination or urgency, that is urge to urinate regularly multiple times continuously, or there may be urinary retention. All of these symptoms occur due to chylous clot hematuria. Okay. Now it can also present as clot colic. Clot colic is sudden flank pain, particularly which is seen after urination. Besides this local symptom, there may be systemic symptom also like weight loss, chills, or peripheral edema. Now if this Chyluria is associated with parasitic infestation, almost always 100% of the cases will have genital manifestation, that is genital swelling. Around 25% of the cases will have lymphatic obstruction in the limb, and 5% will have cellulitis, abscess, and hematuria. So this lymphatic swelling is seen in 25% cases. 5% cases will have cellulitis, hematuria, or abscess formation, whereas almost 100% will have genital organ involvement. Okay. Now coming to the grading of the Chyluria, there is no hard and fast rule to grade. Different author has mentioned different methods to grade. Age-old method of grading is based on clinical feature as well as retrograde study in the radiology. Okay, IV retrograde study. Clinical feature, and based on the retrograde study, it is divided into mild, moderate, and severe. Mild Chyluria is said when there is intermittent episode of milky urine. Moderate is intermittent episode of milky urine along with clot colic symptom. Clot colic is flank pain, alright, intermittent flank pain during urination. Severe is when there is persistent milky urine and one or more of the following, that is urinary retention, hematochylorrhea, or systemic symptom. Systemic symptom like weight loss, chills, rigor, fever, all of this include the systemic symptom. In imaging study, mild is only when there is single calyx involvement. When there is two or more calyx involvement, that is moderate, and when almost all calyx is involvement along with ureter involvement, it is severe. Recently, there is new grading of Chyluria system developed in which it is divided into grade 1, grade 2, and grade 3 based on the symptoms. Only clinical criteria is included here. Grade 1 consists of no more than one episode a year. Okay, so grade 1 is only one episode a year and no chylus clot. Grade 2 is also no more than one episode, but along with it has got chylus clot. Okay, there is chylus clot symptom or retention symptom. Grade 3, when there is two or more symptom a year associated with chylus clot or associated with chylus clot symptom, retention symptom, or anemia. Okay, anemia here signifies that significant hematuria is going on, for which anemia is manifested in the patient. Now coming to the investigation, what we need to do to identify chyluria is, first is urinalysis. Urinalysis is the first and foremost important step for diagnosis of chyluria, and it is usually preferred postprandial specimen. Postprandial specimen, why? To check for the triglyceride level. Postprandial specimen is preferred for this thing. Okay. Now usually in urinalysis we go for the early morning clear catch urine sample, but in case of chyluria we go for postprandial specimen. Now estimation of urinary chylomicron. Estimation of urinary chylomicron is the most sensitive. It is the most sensitive as well as specific test for chylomicron. Alright. And urinary triglyceride level is present in around 100% cases of chyluria, and it is said that if it is urinary triglyceride level is more than 15 mg per dl in any urine sample, it indicates that chyluria is there. Now to find the cause, we may need to see the biliary antigen detection. It can be either from the serum or it can be from urine, and usually ELISA, standard ELISA method is preferred from others. Okay, this ELISA test has specificity of 85% and sensitivity of 95%. Now coming to the radiological investigation, ultrasonography can be used to identify any sort of renal abnormality. Alright, it can be used to identify any sort of renal abnormality as well as blood clot with chylus in the bladder. Alright, CT scan can identify fat within the bladder, as well as dilated lymphatics. MRI is the most useful imaging methodology. Alright, MRI is the most useful methodology where the fistula tract, if present, can also be identified. And it also helps to delineate the anatomy of the bladder and the fistula more properly. Renal biopsy is only indicated if we are suspecting something like glomerulonephritis or a nephrotic syndrome presenting as chyluria. Alright, nephrotic syndrome. Lymphangiocintigraphy is allows for road mapping of the lymphatic transport and drainage system. It typically uses technetium 99. It uses technetium 99 albumin sulfate colloid to identify the pathways of lymphatic drainage in the body, and it can easily identify the site of fistula properly, and it is one of the best non-invasive method of diagnosing the site of fistula. It also provides an assessment of the degree of reflux and is useful for detecting any possible recurrence, and very helpful to assess the prognosis of any sclerotherapy or any further treatment goals. So this is a picture of lymphangiocintigraphy. This is before surgery. These two are before surgery. Here clearly we can see there is blockage leading to collection of lymphatics here. Okay, collection of lymphatics in the upper thigh region. This is the post-surgery picture. We can see clearly that lymphatic flow is well established through this lymphangiocintigraphy. Alright, lymphangiocintigraphy. Now, coming to this flow chart, which we'll discuss about all the treatment in detail. So, what is to be done and how it should be done in case of suspected chyluria? The diagnostic test should involve first to rule out parasitic cause, which is most common in our region, in the developing region, that is filariasis. And we can check for urinary ELISA, urinary antigen ELISA, or as well as serum antigen ELISA to check filariasis. Also, we should do side-by-side urinalysis, and for urinalysis, postprandial sample is prepared. Radiological is ultrasound, cytologram, MRI, lymphangiography or lymphangiocintigraphy to delineate the proper region of blockage. Cystoscopy plus retrograde studies for grading properly to see how many calyces are involved, whether ureter is involved or not. Then we go for the grading. Based on the grading and severity, we check for the treatment. If it is like parasitic cause, obviously we need to treat it first through pharmacological method. Otherwise, initially we start with conservative approach. If it fails, we go to minimally invasive approach, and if minimally invasive approach fails, we go for surgical approach. Alright, now let's discuss one by one all those treatment methodology. Coming to the conservative approach includes high fluid intake so that lymphatic flow increases. In dietary goal, plan should be fat restriction and high protein diet, as well as intake of multivitamin and green leafy vegetables. Natural history of chyluria is unknown, and up to 50% of the cases resolve spontaneously with conservative treatment, and this has success rate of in around 70% cases. Alright, now a high fluid intake is recommended in mild case. A modified diet such as high protein, multivitamin, green leafy vegetable with fat restriction is that is less than 25 gram per day can be sufficient. Fat free diet are recommended wherever possible. It is advisable everything should be cooked in low fat medium chain triglyceride, that is which is less than 12 carbon atoms. For example, using coconut oil for cooking the meal. Alright, coconut oil for cooking the meal. And as this low fat medium chain triglyceride are absorbed directly through the portal system, and it bypasses the lymphatics. System and passes to the portal system directly because of the low size. Whereas long chain fatty acid cannot bypass the intestinal lymphatic system. In conservative approach, if there is lymphadenitis, that is the obstructive pathology, we may offer bed rest to the patient, anti-inflammatory agent, as well as analgesic for symptom control. And all of these are mainly indicated in case of lymphadenitis, that is with obstructive symptom. Chylous clot can be managed with manual bladder wash irrigation in the first instance also. However, the presence of such chylous clot which requires manual bladder wash warrants for more invasive approach, either minimally abrasive or surgical approach rather than this conservative approach. Alright. For this patient with suspected filarial infection, medication is used in combination with dietary therapy. Diethyl carbamazepine, ivermectin, albendazole, as well as benzathine penicillin is tried. The treatment protocol for diethyl carbamazepine is given at the dose of 6 mg per kg per day for 21 days. This drug acts against microfilaria, the larval phase of the parasite. Longer course of diethyl carbamazepine can be required, or treatment course can be repeated after 8 weeks if response is unsatisfactory. Side effects includes itching as well as swelling of the glands, or development of rashes. Now, other medication that can be helpful is like ivermectin. It is given at a dose of 6 to 12 milligram, and then repeated after 3 weeks. Albendazole is 10 to 14 days course at the dose of 400 to 800 milligram per day. Sometimes combination therapy is also used and success is reported. In endemic areas, treatment can be given without demonstrating filarial antigen if it is suspected. So in endemic region, treatment can be initiated even filarial antigen test is negative. Now coming to the surgical method. Surgical method involves the sclerotherapy. This is a minimally invasive technique and it is indicated in patients that have failed conservative or medical treatment. Many different agents have been used such as silver nitrate has been used, providine iodine has been used, sodium iodide has been used, potassium bromide has been used, dextrose hypertonic saline has been used for sclerosing agent. Invasive is considered in patients who have not responded to 2 or more courses of sclerotherapy. Overall surgical, this invasive method has reported 95% of the success rate.